All right, well, we'll just start with some announcements. As you know, the NIH conducted the launch of the Maternal Health Research Centers of Excellence, 10 centers, 2 special hubs, and we obviously we're fortunate enough to be elected as a center for our program PRISM, Preventing Inequities and Hemorrhage-Related Severe Maternal Morbidity, and our launch will take place in October. We have our Dunlevie Fall 2023 seed grants. The applications will close on October the 16th. And we're looking forward to seeing what folks propose from all across Stanford. So next slide. And our next monthly meeting will be in September, and we will have Dr. Elliot Main, one of our own here at Stanford, discussing obstetric sepsis, time for care redesign. But it is my sincere pleasure today to introduce a wonderful friend and colleague, Dr. Cynthia Gyamfi-Bannerman. Dr. Bannerman holds the Samuel S. C. Yen Endowed Chair and is chair of the Department of Obstetrics and Gynecology and Reproductive Sciences at UC San Diego. She is board certified in both obstetrics and gynecology and maternal fetal medicine, and focuses her career on obstetric complications with a primary focus on preterm birth prevention. Dr. Gyamfi-Bannerman is a proficient and renowned NIH-funded researcher working on multiple clinical trials, and she led the transformational multi-center randomized ALPS trial, which was designed to improve neonatal outcomes in infants of women at risk for late preterm birth, published in the New England Journal of Medicine, and which has really changed how we approach late preterm birth nationally and globally. She is long-term NIH funded and has a follow-up study recently completed and pending publication for the long-term outcomes associated with this intervention in late preterm birth. She also conducts research in areas of antenatal corticosteroids, preeclampsia, maternal morbidity, and health disparities, with over 200 peer-reviewed publications. Aside from these fabulous clinical and research endeavors, Dr. Gyamfi-Bannerman serves as a member of the Board of Society for Maternal Fetal Medicine and is currently on the executive committee of that board, serving as secretary-treasurer. She is past chair of the SMFM program committee, and in that role organized the very first virtual SMFM meeting in 2021, and is also past vice chair of the ACOG Clinical Consensus Committee. We are so privileged and delighted to have you here with us today, Cynthia, to talk about antenatal corticosteroids for late preterm pregnancies, history, current practice, and long-term outcome. It is all yours.
Thank you so much. Thank you so much for that kind intro. And it's always lovely to be amongst so many friends here. And I'm very excited to speak to you guys about steroids. Some of you might remember this. It just came to me as I was thinking about speaking to your group. I was actually supposed to speak to you guys maybe 7 or 8 years ago, maybe a little bit longer, and my flight got delayed, and then I didn't make it to Stanford. So I'm glad that I can finally meet with your group and speak to you on antenatal corticosteroids. And so what I'll do is first let me share my screen. But what I'll do is I'll go through a little bit of the history of where we are, how we got to where we are today. And then we'll talk about the long-term outcomes. Those are not yet published. So I'll spend a little bit of time and detail going into what we found. Let me see. I'm going to show you the screen too. I think. No, let me show you the screen then. And then, okay, can everybody see my talk?
No.
Oh, weird. Okay. Let me try that again. I'm sitting in someone else's office today.
Yep,
Alright.
it's coming up.
Okay, great, and
But
now.
we're seeing your schedule.
Yeah, never fun. All right, now do you see the?
Yes.
Yep, that's good.
Fantastic. All right, so a few objectives. First, we'll look at respiratory morbidity for late preterm pregnancies, and you guys all know that. Then we'll talk about the results of the ALPS trial. And then we'll talk about the long-term results, and then my funding is listed below. And from your mouth to God's ears, it will remain funded. Me and I. All right, so here's a study that was published in April of 2016, which seems like a lifetime ago. But was really interesting in that it changed what we do in obstetrics, and it raised the question for a lot of folks, both in this country and outside of this country, as to what we should be doing with late preterm antenatal corticosteroids. So kind of before ALPS, this is what people were thinking about. So the NICHD held a consensus conference. This was initially held in 1994. And the reason for the conference was that, first of all, there was limited data on use of steroids at less than 24 weeks and greater than 34 weeks in randomized trials. Looking back to Liggins and Howie, that was published in 72, only about 20% of eligible pregnancies were receiving steroids. And so there was a lot of concern that we have a potentially beneficial treatment that wasn't being used. And actually, when you look at the history of medicine and you see how, maybe what led to this conference, it was in 1993 that the Cochrane group started to look at meta-analyses. And the first one that they did was antenatal corticosteroids. And they showed the benefit in that meta-analysis. And so kind of clearly, there was a benefit, people weren't using it. So quickly after 1993, and I think that meta-analysis, the NIH got a group of experts together. So the conclusion of that consensus conference was that you could use steroids from 24 to 34 weeks. There was another consensus that came out in 2000, and that was primarily to say stop doing weekly steroids or stop prescribing weekly steroids. But so this kind of became the law of the land. And so I dug back to the 1995 ACOG technical bulletin. And for those of you who might be a little bit younger in the audience, it was great that ACOG used to send you this really big text called a compendium, and they would mail it to your house, and it would have all of their guidance. And this is, internet was still kind of a new thing, but so everything came in this book. And the nice thing about it was that the book didn't disappear the way that outdated guidelines disappear from the internet, from ACOG. But so I found the 1995 technical bulletin, and the way that it speaks to pregnancies is kind of the way that the way we were thinking about pregnancies back then. So it said that the survival rate for babies that were born at 34 weeks of gestation is within 1% of the survival beyond 37 weeks. Back then, 37 weeks was essentially considered full term, even though we call it term today or early term. But the thought was they do just as well. And so we used to deliver a lot of babies at 34 weeks. This particular bulletin also defined tocolytic success as until 34 to 35 weeks, when nearly all neonates do well. So it was kind of thought that if you reach that threshold, everything is going to be okay. I put here before 2005 because there was another consensus conference that came out at 2005 to define late preterm. Before that time, that the phrase actually didn't exist. And if you do a PubMed search and you kind of put the dates before 2005, you will really not find anything on the topic. And then after that point, you find, hundreds and thousands of literature on the topic. So in the 1990s and 2000s, there were a lot of papers that were showing that there was respiratory morbidity for late preterm infants. Several of them cited here. The first, the table here is from the Italian group, basically showing that if you compare them not to early pretermers, but if you compare them to people who were born at term, there was actually a much higher incidence of RDS and TTM. And so neonatologists were talking about this because on the OB side, we kept finding them babies that were late preterm, and they kept staying in NICU. So this is another big problem. So like I mentioned, in 2005, the NICHD decided to convene obstetricians and neonatologists to talk about what is this issue of respiratory morbidity in these infants that are being delivered. This workshop defined late preterm with a very particular emphasis on preterm in the title and not near term, which is the term that neonatologists were using to describe these babies to emphasize that they're preterm. And so this was a really important, I think, incredibly important workshop. And it really kind of changed the thinking that was described in that technical bulletin. One of the first and probably largest papers at the time to describe morbidity in late preterm infants, respiratory morbidity specifically, was a secondary analysis actually of the Safe Labor Consortium, and it was published in JAMA now about 13 years ago. And what they did was they looked at short-term late preterm respiratory morbidity. They compared that to infants that were born at term, and essentially it was a retrospective cohort. So looking at some of the findings, you'll see respiratory morbidity by gestation age at birth, and I don't know if you can see my mouse, but here on the y-axis you have gestation age at delivery, and then on the x-axis you have all of the respiratory morbidities, and you can just see that they're increasing as the gestation age decreases. And so essentially what we were talking about, at these workshops was being observed in the clinical literature. Here was just if you just look at RDS and nothing else on that table, these are the adjusted odds of RDS by gestation age at birth. So you can see that at 34 weeks, it was the odds were 40-fold higher. And then here at 37 weeks, you actually had 3 times the likelihood of RDS. So it started to look at kind of that early term was not the best either in terms of your respiratory morbidity, but certainly late preterm was bad. And then ultimately, in looking at this slide, looks at respiratory support in a typical NICU. And when you look at the 34, 35, and 36-week group, you can see that they actually require the most respiratory support of anyone in the NICU because there's more of them. So preterm birth is more likely to be late preterm birth. The vast majority of preterm birth is late preterm birth. And so they're using respiratory support in large numbers. And so that was something kind of to keep in mind. So then going back to this workshop, the NICHD and just NIH workshops in general have a research section where they ask, what are the questions of the day? What do we need to answer in 2005? And the research question that they had was, should we assess, or one of them anyway, should we assess whether current interventions such as antenatal corticosteroids are beneficial for late preterm infants? So this was, kind of the perfect question for me because I was also asking the question, and when I saw that NICHD was asking the question, it became something that became imperative to answer. And so that is the background that led to the ALP study. And so I will just very quickly summarize the results. It was a multi-center study. There were 17 centers that participated, including yours. And the question was whether administration of betamethasone to women who were very likely to deliver in this period would decrease their respiratory morbidity. We did quite a bit of due diligence in designing the study and then thinking through all of the unknowns of antenatal corticosteroids. And we felt pretty strongly that in this group, it might not be RDS that we were going to show a benefit towards, but that it would be transient particularly to newborn. And we had some animal model studies that showed that if you gave actually the dexamethasone to fetal lung fluid, that the sodium channels, which are the channels that switch when the fetal respiration goes to adult respiration, that would switch after about 8 hours. So we said, okay, so maybe we don't need, the whole 24, 48 hour steroid complete, thing that we use clinically. Maybe we'll see a change in as early as 8 hours. So we really focused on that and focused on, the TTN aspect and not RDS. In order to be eligible, you had to have either active preterm labor, and we defined that very specifically, or if you ruptured membranes, which is fairly easy because that was a clearer indication, or if your provider said you were going to have an indicated late preterm delivery, then you were eligible. Anyone who's practiced clinically knows that it's very hard when someone is late preterm and they're in your triage to know, are they going to go home or are they going to deliver? And so we had some very strict criteria surrounding preterm labor injection. There were a ton of exclusions, including diabetes, pre-gestational diabetes, only because that would unblind the study because you would know because the mom's blood sugar would go up. And so that's why we excluded diabetics. And most people were excluded when when they arrived in triage. So most people were not eligible. Most late preterm pregnancies were not eligible for steroids. We randomly allocated them to 12 milligrams of beta-medicine or placebo. We didn't localize them, so we didn't want to study two different interventions. And it's actually so interesting. I'm preparing a talk for the European Spontaneous Preterm Birth Group. And when you look at the original Liggins and Howie study, what they did after they published the first part of their study, they actually doubled the dose of betamethasone. It's really interesting. So a group actually from Auckland went back through all of their records and showed that they actually then went to 24 milligrams, 24 hours apart, because they said, well, we decreased RDS, can we see if we, decrease it even further? But that's really human there. But for ALS, we did 12 and 12. And then our primary outcome, after interviewing neonatologists really all around the country, we came up with something that was kind of predictive of what you would see with bad TTM. So the oxygen requirement, the CPAP, mechanical ventilation, or ECMO, they had to occur within 72 hours of birth, or a stillbirth or neonatal death. And then that secondary outcome, we also just extended the oxygen from 4 to 24 hours and CPAP from 2 to 12 hours. And then these were our results. So in our main study outcome, there was benefit. The number needed to treat was much lower than we thought. And then in the secondary respiratory severe morbidity, also a benefit. There is an erratum that we actually published in the New England Journal that they kind of snuck in there somewhere. Turns out the number needed to treat was actually 24, and that the differential findings that we were finding with vaginal deliveries versus cesarean in the greater than 36-week group didn't actually exist. And the person who had done the initial stats for this used the wrong variable. That's really interesting. It took them a long time to publish the erratum. We had sent it to them. They actually lost it. It's very interesting. No offense to the New England Journal, but I was very surprised. And after several years, they finally put that in there. So that it was even a little bit more beneficial. In terms of some of the neonatal secondary outcomes, you can see that actually there was a significant decrease in the need for resuscitation at birth, which we thought, I think we used a kind of a good composite outcome to find some of these things. TTN, as we suspected, was a little bit decreased in the steroid group. Bronchopulmonary dysplasia was actually decreased, and that was a surprising finding to us. And then, surfactant use also was less. So again, translating our outcome into actual clinical practice. What about hypoglycemia? So we were actually surprised in some of the other secondary outcomes that hypoglycemia was higher in the steroid group. But I remember when they revealed the outcome, and I was like really, really surprised by that, knowing we had included hypoglycemia because it's just more commonly featured in infants. But in looking back at all the other steroid studies, they hadn't seen that. And so it was really surprising to us that we found that. It did translate to a earlier time for first feed. So much earlier in the betamethasone group, which was this first comment here. And they ended up with significantly shorter, in terms of NICU stays, they had less of a longer delayed duration of NICU. So hypoglycemia was very interesting to us. And the reason that it was surprising and a little concerning is that we know that prolonged and persistent hypoglycemia is associated with neurodevelopment and delay. The problem is that no one has ever defined prolonged and persistent hypoglycemia. I think most people think that's about 72 hours or longer in the neonatal world, but there's not a specific defined threshold that I think people agree with, nor is there a defined definition in terms of like numeric definition of hypoglycemia. So we wanted to look into this, and the very first question was, is our hypoglycemia persistent or prolonged? And so we did another study, which we published 2 years ago now, that looked, basically re-abstracted all of the available charts in the ALPS trial. So this is a secondary analysis of ALPS, and we were able to get 92.2% of the participants. It was originally about a little over 2,800 and got 2,609. The reason, probably the primary reason that we didn't get more, was that there was one center in Texas that had been part of the network and it was no longer a part of the network. And they were just not willing to put in, the effort and time and money to re-abstract all the charts. And so really it's kind of one center that's representing the missing charts and not, not any other variety of missing charts. But either way, the initial ALP study used a binary outcome for ALP. So it was hypoglycemia, yes or no. And that's what's reported in the primary study. So what this secondary analysis did is that we actually went through all of these 2,600 charts very painfully and looked at all of the glucose levels that were reported and recorded all of them, recorded the lowest ones, looked at the duration of hypoglycemia, and then looked to see was there any treatment at all for those who were hypoglycemic. So the first thing we looked at was, when was kind of that first occurrence of hypoglycemia between betamethasone and the steroid group, and for the vast majority, that first outcome was within 0 to 24 hours. Then we looked at the lowest glucose value, and they were identical. So the betamethasone group went down to about 31, same for placebo. And then how many received treatment? So no difference in the numbers that received treatment as well. But importantly, the majority did not require a treatment for hypoglycemia. So they probably were all fed because the other treatments, actual treatments aside from feeding, were what we were looking at there. So probably just the early feeding was what resolved the hypoglycemia. But then the more important question was, how quickly did it resolve? So did we have prolonged persistent hypoglycemia? So what you'll see, and I think you're seeing this mouse here, is that the blue is betamethasone and the pink is placebo. So the time to resolution of the hypoglycemia was much quicker in the betamethasone group, significantly. So 2.8 versus 3.7 hours, and most of it resolved within 6 hours. And then you can kind of see what the rest looks like. But most of the hypoglycemia resolved within 6 hours. So, we felt, I think, a little bit better about that. So that paper was published a couple of years ago and helped us to get a little bit more of the data from hypoglycemia. Then we did a cost effectiveness analysis. Actually, temporarily, we did this one before the other one. But the cost effectiveness analysis kind of looked at maternal and neonatal costs. So on the mom side, we said, what was the cost of the steroid? And then what was the cost of her having to come back for administration if the patient was discharged for whatever reason? So that was kind of the cost. Otherwise, if it's an inpatient, then there was not like an additional cost to getting the symptoms. And then on the neonatal side, we looked at the cost of the level of respiratory support and the daily physician cost that was reflective of that level of care. And basically the findings were very similar to the findings in the primary study. Betamethasone was more cost-effective strategy compared to not having human skills treatments. There are also a lot of data to show, even when you're looking at RDS, when you pool all of the late preterm studies together, there actually is a reduction in RDS, and the Cochrane review showed that first in 2017, and in all of the updates, it's been the same. So actually RDS has also decreased for this group. So in terms of what is the current practice, well, it hasn't changed much. The initial statements came out from SMFM and ACOG right around, so both in 2016 and both very, very early. And the reason for this was that they didn't want folks to think that the use of steroids at greater than 34 weeks was going to be the same as the use of steroids at less than 34 weeks. And it was very important to get out there that if you have a severe preeclamptic who's 35 weeks, you're not going to wait until they're steroid complete before you deliver them. And so I think that's the reason that a lot of this came out very quickly to say, if you're going to use steroids, use these parameters or these guidelines. And it hasn't really changed much since then. There was an update, I think, from, I can't remember, if, most of these were written jointly, but I think there was an update to say that, we'd like to have more long-term data. So this was a study that folks in Boston invited me to participate in, and basically what they did was they looked at birth certificate data, and they did a time-limited analysis to show what was kind of the uptake or the change in use of antenatal betamethasone kind of pre and post the ALP study. So they looked from 2015 to 2017. So the first thing they looked at, so if you see this line here, this is kind of the expected, right? This is what was going on in 2015 with the use of antenatal corticosteroids, and you kind of expect that if nothing changed, it would just kind of go along this trajectory. So it was increasing slightly, and if nothing changed, it would just do that. The grayish period here is from February to October 2016, and that's kind of the ALPS was presented at SMFM in February, published in April of 2016. So they're giving a little bit of time here to see change in practice, and they want to know what happened in terms of steroid use. So this is what happened in terms of steroid use. All of a sudden, kind of from the time that the study was kind of first discussed until here, 2017, when they stopped looking, there was quite an increase. Of course, you look at your y-axis, it's not, it's not 100%. But so of deliveries that were late preterm, the exposure to steroids went from 5% to about 15%. So there's a pretty significant change in practice there. But did that mean anything for the respiratory support? So they're able to look at that with birth certificate data, and they found that, so this would be the trajectory of expected change in respiratory support over that time period, and this is actually what happened. And so they're saying that, in fact, there was a decrease in respiratory support amongst infants that delivered in that late preterm period. Of course, this is birth certificate data, and so it has all of the, you can't take too granular of a look, but at a population level, there was a decrease in respiratory support. So now what about long-term follow-up? So long-term follow-up is incredibly important when you have a randomized trial that changes what people do in practice. And so we kind of initially had wanted to do a long-term follow-up when we first presented the study, but I guess without knowledge of what the outcome was, and also because of funding limitations, whatever, they did not fund a long-term study from the inception of ALPS, and so we have to go back and ask them, can you please do it now once we have the findings. But let's go back to see what others had done previously. So I kind of briefly mentioned Liggins and Howie. Their landmark trial obviously changed practice as to what we do. They included women who were admitted in preterm labor or had an indication for delivery from 24 to 36 weeks, and a lot of folks don't realize that they included all of late preterm, but they did. You were excluded only if you had some contraindication to steroids or you were thought to deliver too soon. And then you were randomized, at least in the first version of the study that was published, 12 milligrams of betamethasone. The placebo was actually hydrocortisone, which is not crossed with somewhat well, and the 7th is potent. And if you're pregnant, after 24 hours, you got that second dose. So these are their findings. If you think about 1972 for a moment, viability was 28 weeks at the time. And so there were no survivors under 26 weeks. And really the study is skewed towards late preterm infants. But you can see that there's markedly less RDS if you were exposed to betamethasone versus placebo. And then here, this actually approximates the late preterm period, but you can see that there actually is about the same reduction in RDS as noted in the ALPS trial, so about a third reduction. They're exposed to betamethasone, no RDS at term, which is not unusual, and so overall, a benefit. But no one was using it, and we spoke to why there was the NIH consensus conference, but there was some harm that was thought to be noted in animal models. It was thought to be more beneficial in one journal over another, and there were lots of concerns about the risk of infection, particularly in the setting of PPROM. And actually, during the time of my residency, and I'm sure many of you might remember this, that we actually stopped giving steroids around 30 to 32 weeks if someone had PPROM. We were concerned that it might cause a really bad infection. And so those were kind of the things that were going on at the time, and so no one was really but Liggins and Howie performed a 6-year neuro follow-up. So this was published in 1982 in Pediatrics. And so what they did was they took their original cohort and tried to follow up as many as they could. And here are the gestational ages for the betamethasone and the control group. And so you can see that it's pretty much all late preterm. And they, had kind of similar numbers in both groups, but they were delivered kind of around the same time. And then they did for them IQ testing and speech and language, memory, attention, and all of these, all of the things you'd like to know, and actually found no difference between groups. So that was, a very good sign. And they were able to do a 6-year neuro follow-up. I think that's why looking at some of the older data, I think folks were maybe a little bit more comfortable that there was actually more known about, late preterm exposure to steroids than I think others. But then they went on to do a 30-year follow-up, which was just really amazing. and probably somewhat facilitated by being in New Zealand, where not a lot of movement. But really impressive still to have a 30-year follow-up. The mean gestational age of steroid dosing was from about 31 to about 34 and a half weeks, and the median gestation of delivery was actually 35 weeks, so again, late term. 34% of them went on to deliver at term. There's a lot of talk in the literature about what if you get steroids and then deliver at term, but that was the case here in this 30-year follow-up. And again, it was they did IQ testing then, it was normal memory, normal attention, and really no difference between the two groups. So this is published in 2005, quite some time ago, and a lot of reassuring data that existed prior to the follow-up. And then there's the Aztec trial, which was a term steroids trial done in the UK, published in 2005 also. It wasn't blinded, there wasn't a placebo, and there's a lot of criticisms about a lot of trials, but there's some criticism about this trial as well for those things. They had about 1,000 women with scheduled C-sections at term, 37 to 42 weeks, who were randomized either to get betamethasone and then deliver, or wait a couple days and then deliver by C-section. The primary outcome was NICU admission for respiratory distress, and they actually found a difference. And then when you look specifically at the early term group, 37 and 38 weeks, you can see that there's actually quite a difference. And so it was interesting looking at that data, that if you saw that, at term, then certainly late preterm, you'd see a benefit. And remember, this was all published before ALPS was started. But importantly, I'm bringing this up because this group with term exposure to steroids did a follow-up that was published 10 years ago. And they looked at asthma and they looked at other health outcomes, including, IQ testing and all of that. So the mean gestational age of exposure to steroids in this study was 38 weeks, and the mean follow-up age of the child was 12 and a half years. And there was no difference for asthma, for nerve development, or for any of the other health outcomes. So as we were thinking about the ALPS trial, there was a lot of, I think, literature being published looking at, well, what would potentially, how can we proxy what the long-term outcomes might be if you're exposed to late preterm steroids? So I think a lot of people had some interest in that, and there were a couple of things that were published in JAMA that, were maybe not the best in terms of the study design. So some that, explicitly had an unknown gestational age of steroid exposure. So when they got steroids versus when they delivered is not known. They just say they delivered in the late preterm period, but they don't know when they got steroids. There are a lot of retrospective cohorts, some of the data observational, and then there's selection bias, because if you only look at live births, then you've eliminated the folks who might have had a different outcome, who might have made the outcome different. So anyways, there were a lot of flaws. We wrote a couple letters to the editor to try to say that these studies could be done better. But there are a lot of people who are saying we really want to see the results of the follow-up study for the ALPS cohort, and so we were able to show those to folks at SMFM last year. And so I'll show them to you. As was mentioned, they have been submitted for publication actually last month, and so we're just waiting to hear where they ultimately end up. But I'll spend some more time since this is not searchable yet. So we essentially wanted to see if late preterm fetal exposure to antenatal corticosteroids affected childhood nerve development. So this is a follow-up of children of mothers who participated in ALPS during the parent trial, because we were always thinking of doing a follow-up. We actually went and consented everybody for the option to opt in for future follow-up or future consent. The child, in order to participate, had to be at least 6 years old, and the child had to have the ability to participate. And for many reasons, there were two parts to this study. One part was respiratory, and one part was neurologic, but they had to be able to do the procedures. In terms of cognitive testing, what did we actually do? So we did the DAS-2, which is essentially an IQ test. It's in the neurodevelopmental world, I think it's kind of replaced the LIPSI and the LISC as IQ tests. So the DAS-2 is the one that we chose. And there's a general conceptual ability score that includes verbal and nonverbal reasoning and spatial ability. On the IQ score is 100 would be the mean, and then 15 standard deviation. We also looked at the gross motor function classification system, which is more for kind of cerebral palsy and motor delay. We did, which I think is new and different, the social responsiveness scale. So that's an autism screen, and I don't think the steroid studies have really looked at autism in that way. And the childhood behavior checklist is also another test for autism and social competencies. And then we asked the caregiver about the child's health, and this is really related to their respiratory health, but a whole host of questions. In terms of our study outcomes, the primary was the GCA score on the DAS2. And like I said, so we looked at one standard deviation below the mean, which is 85. Most of the studies that use an IQ score will use 2 standard deviations or a score of less than 70 as abnormal, but we thought we would want to look at more modest differences because, you know, hopefully we wouldn't have, you know, a large difference in less than 70, which is pretty marked. So we use it. Importantly, the caregivers, the research staff, and the investigators remain blinded to the original treatment assignment of the study. In the secondary outcomes, we looked at all of the subcomponents of the DAS2, again, the positive screen on the SRS, the childhood behavior checklist subscales, and then the gross motor function classification system level. So I'll go through where we found the subjects for this, this study. So there were 2,831 that were enrolled in the original ALT trial. Then upfront, 409 were excluded. So there were 209 from sites that were no longer participating or no longer part of the network. Of the participants in the original trial, there were 186 who declined future contact, and so that we have to respect that, obviously. And then there were 9 infant or neonatal deaths, 4 that were lost to follow-up in the original trial, and there was 1 maternal death. So of the original ones, we had 24, 22 that we could assess for eligibility. And that's where we had our largest exclusion. So almost 1,400 were excluded there. And of those, the largest reason was the inability to contact the participants. And, you know, I know that the folks, you know, at Stanford, no, we tried really hard to find these participants. We actually, aside from email, social media, snail mail, phone calls, we had a web page, but then we actually hired this group called Omnitrace. Omnitrace used to work for the government and for the FBI in finding, you know, criminals. That was their original goal, and then they shifted to research. So we actually hired this group to try to track down our participants. And so it really was kind of a labor of love in trying to find people. And there were some changes that happened in I think, the political climate where people didn't want to be found, particularly people living in border states at the time. And then we had a pandemic. So it was going to be really hard to recruit children to come to a hospital in the middle of global pandemic. So lots of things, unfortunately, changed our ability to follow some of these kids up. But suffice it to say that an inability to contact them or declining participation were the most 2 common reasons. But then we also had 25 that were excluded for autism, severe autism or developmental delay who could not finish the maneuvers in the study. And so we really wanted to look at that because that was going to be important. And then the rest you can see, facilities, etc. So of after the ones that were excluded, we enrolled 1,026. And of those, there were 77 that had this missing data. And so of the ones with DAS2 scores, we ended up with equal groups, 479 in the betamethasone group and 470 in placebo. So first we wanted to look at what are some of the characteristics for participants who were able to enroll in the follow-up versus the ones who were not able to enroll. So were they the same? Because we didn't want to recruit a biased group. And essentially there were no significant differences. So the age was slightly younger, 28 versus 29 for those not enrolled, and there was a little bit more smoking also in those not enrolled. And then the other differences were that there was more private insurance in the ones that were enrolled, and they were more likely to have a college degree. I know I recall that, so there were 25 that were excluded because they had severe developmental delay or death and could not participate. So we wanted to look at that by treatment assignment, and so we did that. So there were no differences essentially in autism or developmental delay or death between the betamethasone or the placebo group. So that was, I think, important to us. And now, what about the ones who were actually included in the follow-up study? So we looked at their characteristics by the original trial, and you can see that they were slightly different in terms of race, ethnicity, and as in the parent trial, there was significantly more hypoglycemia in the betamethasone group. And then when you look at the children from the follow-up study, the average age that they were enrolled was actually 7 years old. And again, some slight differences in race and ethnicity. And then we also look to see, if, in terms of the degrees that the mother or caregiver had, and they were similar. So now here's the primary outcome. So this is the abnormal GCA score. And when you look at it, the abnormal score was not different between groups, slightly lower in the steroid group, but this was not significantly different. And so they had the same in proportion of abnormal scores. And then when you looked at the numeric score across all of the domains, again, there was really no difference between the two groups. We looked again at the social responsiveness scale. So that's the one that's related to autism. So a lower score there is better, or a lower percentage is better. And there was no difference between the betamethasone group or the placebo group, and no change in terms of their motor level. And then again, the CBCL was the test for autism. Again, a lower score there is considered better. And there were no differences between the groups for that as well. So there were no significant differences in any of these cognitive tests that we did between the two groups. And importantly, so we went by the original treatment assignment for this analysis. And so even though there was much more hypoglycemia in the betamethasone group, we still didn't see a difference in terms of their cognitive outcomes. So what is the bottom line here? So we know now from our data and combined with other data and meta-analyses that antenatal corticosteroids improve short-term late-term respiratory morbidity, not only in a randomized trial cohort, but we actually were able to demonstrate that on the population level with that data. We also were able to show that hypoglycemia in this group related to steroids is transient, but actually longer in the placebo group and didn't affect any of the immediate neonatal outcomes. The long-term data that we have shows no difference in their development despite more hypoglycemia in the steroid group. And there's a lot that we're looking at for future research. So I mentioned kind of specifically that we still had this the study we presented earlier this year as an MFM with our treatment assignment, but what about just hypoglycemia in general in the late preterm period? So we think that that's a really interesting question that we are hoping to present the findings of this year as an MFM. So in a late preterm cohort, does hypoglycemia affect the neurodevelopmental outcomes? We're also looking at the childhood neurodevelopment by the indication for late preterm delivery. Still with the question of, is infectious morbidity worse for neurodevelopment? We're looking at long-term respiratory outcomes after late preterm birth and hoping to publish that paper soon. And then air pollution and childhood respiratory outcomes is a really interesting question, and we have the data to be able to answer that as well. So thank you very much for your attention, and I'll be really happy to answer your questions.
Thank you so much, Dr. Gyamfi-Bannerman, and I believe Deirdre has her hand up.
Yeah, thank you. That was, wow, that was an amazing talk, and I'm so impressed by your ability to persevere in the follow-up studies, because that is a lot of work, but really interesting and really practice-changing useful stuff. One question, I didn't realize that the patients from the original trial were excluded with pre-gestational diabetes because of the unblinding. That makes sense. Mm-hmm. I'm curious then, in your practice, just given that this is a group that's at greater risk for respiratory compromise, what do you do and what do you recommend? I don't think anyone's going to recreate this study in that population, but I'm curious as to what your thoughts are.
No, it's a great question. You know, I'm very hesitant. I am a little bit of a stickler to following the protocol, and so I don't recommend it in diabetics. You know, it's all about risk benefits, and sometimes just trying to get glycemic control in some of these folks is so challenging. So I mean, I have never used it. I've definitely been amongst colleagues who have, but it's not something that I recommend.
Cynthia, I have a question along the same lines that relates to twins. Is your answer the same?
It's similar. We wanted to have the original ALPS trial had a singleton strata and a twin strata, because if you look at Cochrane analyses and you look at twins and antenatal corticosteroids, you might stop using them because there's no benefit proven in twins ever. And so we didn't want to just lump them in with singletons and then make our study negative. So we wanted to look at it. We didn't look at it. I personally don't. Just about everyone around me does. Maybe one day I will, but I personally don't for 6 weeks.
Someone's asking, what about for gestational diabetics, not pre-gestational? That was part of the ALPS trial if they had GDF.
And the only reason it was part of ALPS was because the NHLBI said we weren't recruiting fast enough. They actually were originally excluded, and then NHLBI said you gotta add something in because you're not finding patients fast enough. So we added them back in, and thankfully we did, because I feel more comfortable for a gestational diabetic. If they're really poorly controlled, I might not.
Cynthia, I'm just looking here at seeing what other questions pop up, but as I have just two questions. One is, you know, the 2005 study on the early or in the term gestation, it's quite tempting to think of. Do you think a study will ever be done on early term?
You know, I don't. I had one. And I was thinking about proposing one or thinking about doing one. Maybe in the setting of C-section, but the numbers, when you think about the numbers of kids who would get exposed to steroids, you know, I mean, I think it's fine when you're at risk and you can clearly see a benefit, and you might see a benefit at 37 weeks, but it's kind of diminishing as you get to term, and also there're just so many more term babies. So yeah.
Okay. And my last question, unless Ron has something he wants to say here.
I do, Cynthia. Powerful presentation and a wonderful story. There were 6 maternal deaths in the follow-up of the 1,300 cases. That's several-fold higher than we would expect. What were the causes of those maternal deaths?
Most of them were accidents.
Wow.
Yeah.
Wow.
Yeah.
Yeah.
Thank you.
And Cynthia, the last question. What is your biggest concern around misuse of the ALPS trial? Is there misuse? What things have you seen that have concerned you?
Well, it seems to me that, you know, there's camps who were kind of not in favor and slow adopters, and there's camps who were like very quick adopters. I think the quick adopters will give everybody in triage who comes with preterm labor and they're maybe like fingertip, and they'll give them steroids. And so many of those never needed them or going on to term, and it's not really kind of following the spirit of what was meant by ALPS. You have to be about 4 centimeters or something. That's not happening. And so, you know, I think it's not really intended for folks who are going to deliver at 39 plus weeks. And so I think that people should be more judicious about using it. But so, you know, that's the thing I see that's a little bit concerning. And then, you know, if you have a sick diabetic or someone who's septic and then they get steroids, you know, that doesn't seem to make sense.
Or delaying delivery in a risky way just to get the ALPS steroids on board.
Right. Thankfully, I've seen a lot less of that, but yeah, that would be very good.
This has just been fantastic. We're so honored to have you speak to us, Cynthia, and thank you. Thank you so much.
No, thank you for having me. It's a pleasure. I really appreciate it.
We'll talk soon.